Welcome back to the Deep Dive. So you're just starting your neurology rotation, and our goal today is to really get into the clinical pharmacology of Parkinson disease treatment.
Exactly. We're going to use the case of Neil. He's a 68-year-old retired architect, and he's just been diagnosed with PD.
And for our listeners, you already know the pathology here. It's that loss of dopaminergic neurons in the substantia nigra.
Oh, right. But the key clinical point is that by the time Neil actually has symptoms, the tremor or the slowness, he's probably already lost over 80% of his dopamine capacity.
80%. That is a huge deficit to overcome.
It's a massive deficit.
And that's really the challenge, isn't it, overcoming that? But it's crucial to remember, for Neil and for any patient, that everything we're about to discuss is for managing symptoms.
100%. The entire mission here is to replace that missing neurotransmitter, to restore the signaling. We have to be clear, though.
What's that?
We have no therapy right now that slows, stops, or reverses the underlying neurodegeneration. We are managing symptoms. We are not curing the disease.
Okay, so let's start with the absolute cornerstone, levodopa, LDOPA. It's been the most effective drug for decades.
It really has.
But why can't we just give Neil a dopamine pill? Why is dopamine itself useless for this?
It all comes down to a transport problem. Dopamine is a catecholamine. It's big, it's polar.
And that means it can't cross the blood-brain barrier.
Exactly. The BBB is a very tight gate, but LDOP, it's the metabolic precursor to dopamine, and structurally, it looks just like an amino acid.
So it gets a free pass.
It gets a free pass. It uses the L-type amino acid transporter to just waltz right across the BBB.
So LDOPA is basically the Trojan horse.
Mm-hmm.
It crosses the barrier, gets into the brain, specifically the striatum, and then what? How does it become dopamine?
Once it's inside the CNS, it's converted very quickly into dopamine by an enzyme called aromatic L-amino acid decarboxylase, or AADC.
And the few surviving neurons just soak it up.
They do. They take up that new DA, package it into vesicles, and release it. That's the whole mechanism. You're restoring the missing signal.
Okay, but the body is, let's say, annoyingly efficient. That ADC enzyme isn't just in the brain. It's everywhere.
It's absolutely everywhere. And that's where the second drug in the pill, carbidopa, becomes essential.
So what are the two big problems that carbidopa solves?
They are efficacy and tolerability. If you gave LD-dopa by itself, most of it, 90% or more, would get converted to dopamine in the periphery.
In the gut and the bloodstream.
Yes.
Yep.
And that creates two huge problems.
Problem one?
Efficacy plummets. Less than 1% of the dose you gave would even reach the brain. It's just wasteful.
And problem two must be the side effects of all that dopamine floating around outside the brain.
Devastating side effects. We're talking severe nausea, sometimes really intractable vomiting, and significant orthostatic hypotension. Your blood pressure just drops when you stand up.
So carbidopa is the bodyguard. It blocks that peripheral AADC enzyme. But here's the key question. If it's blocking the enzyme that makes dopamine, why doesn't it shut the whole process down inside the brain?
And that is the high yield point. Carbidopa is a peripherally acting inhibitor. Just like dopamine, it's polar, and it does not cross the blood-brain barrier very well at all.
Ah, so it acts like a shield outside the CNS,
Yeah.
letting the LDOPA get to the brain safely.
Precisely. It protects the LDOPA in the bloodstream, but once the LDOPA is in the brain, the ADC enzyme there is untouched and ready to work.
And that pairing is just brilliant. You boost the amount of L-dopa getting to the brain from less than 1% to about 10%.
And you dramatically reduce those awful peripheral side effects. The combination is absolutely necessary for Neil. You almost never see L-dopa prescribed alone anymore.
Okay, so let's pivot to the very first decision Neil's neurologist has to make. For a newly diagnosed patient, especially at age 68, the first-line therapy choice is really dictated by age.
It's a critical decision, and it's all about managing risk over the long term. For older patients, let's say over 65, like Neil, levodopa is almost always the preferred start.
Why is that?
It gives you the most powerful symptomatic control, and it's generally tolerated better from a neuropsychiatric standpoint.
For younger patients, historically, the thinking was a bit different. They often started with dopamine agonists or DAs. What was the rationale there?
The theory, and it's based on some older kind of mixed evidence, was that starting with the DA might delay the onset of motor complications.
You mean the dyskinesias, those involuntary movements?
Exactly. The idea was to save LD-dopa, to preserve that LD-dopa window for as long as possible.
But for Neil, at 68, that risk calculation is flipped on its head. Why are the immediate risks of a dopamine agonist more concerning for him?
Because dyskinesias take years to develop. From older patient, the immediate neuropsychiatric side effects of DAs are the real threat.
What kind of side effects are we talking about?
Hallucinations, acute confusion, and really profound daytime sleepiness, sometimes even sudden onset sleep attacks, which are, catastrophic if someone is driving.
And then there's the most infamous one, the impulse control disorders, ICDs.
Yes. And this is a huge deal. The DAs, drugs like ropinirole or pramipexole, have a much, much higher rate of causing ICDs than levodopa.
And ICDs are things like,
Compulsive gambling, hypersexuality, binge eating, obsessive shopping. For Neil, a retired man who has his life savings and reputation, an ICD could be absolutely devastating.
so for him, the immediate and high risk of these cognitive and behavioral problems far outweighs the more distant theoretical risk of dyskinesia.
Precisely. For Neil, L-DACO-carbidopa is safer, better tolerated, and frankly more effective as a first choice.
And clinically, you have to screen for this, right?
Oh, absolutely. You must screen all patients and their families for these behaviors before starting a DA and then monitor them regularly. But for Neil, we just avoid that risk up front.
Okay, so let's say Neil is doing well on L-Dopepexo for now, but we know the disease progresses. What other tools are in the pharmacological toolkit?
This is where those dopamine agonists do become incredibly valuable just later on.
So ropinirole, pramipexole, and there's a patch, rotogotine. What's their main advantage later in the disease?
It's all about pharmacokinetics. LDOPA has a very short half-life. The effect of one dose might only last 6 to 8 hours, if that.
Which is why patients take it 3, 4, even 5 times a day.
Right. The DAs, on the other hand, have a much longer duration of action. Some last up to 24 hours.
So they provide a smoother, more continuous stimulation of the dopamine receptors.
Exactly. And that is key for managing the motor fluctuations, that awful on-off cycling that develops later. They help smooth out the peaks and valleys.
Okay, let's move to the next class, the MAOB inhibitors. Drugs like selegiline or rasagiline. How do they work?
These are what I'd call DA protectors. The enzyme monoamine oxidase B, or MAOB, is a primary way the brain breaks down dopamine in the striatum.
So if you inhibit MAOB,
You reduce the breakdown of dopamine. You're preserving and enhancing the dopamine that's already there, whether it's the little bit Neil has left or the dopamine he's getting from his LDOPA.
so they seem like a good choice for someone with very early, mild symptoms.
They are. They're great for mild symptoms initially or as an add-on later to help the L-DOPA dose work a bit better, but they're not powerful enough on their own for very long. Most patients will need L-DOPA within 2 or 3 years.
They buy you some time.
They buy you time. That's a good way to put it.
And what about amantadine? It's kind of a strange drug with multiple mechanisms. What's its main role now?
Amantadine is an interesting one. It's pretty weak as a monotherapy, but its most powerful use clinically is later in the disease.
For what specifically?
Specifically for managing the L-DOPA-induced dyskinesias. If Neil starts developing those involuntary wiggly movements, amantadine is often the first drug we reach for to dampen them.
So it lets you treat the side effects of the primary treatment.
Exactly. It can reduce the severity of the dyskinesias without forcing you to cut the L-DOPA dose so low that the Parkinsonism comes back.
That brings us right to the long-term outlook.
Mm.
When Neil starts L-DOPA, he's in what they call the honeymoon phase. What's happening in his brain that allows for that stable benefit?
In that initial phase, he still has enough surviving dopamine terminals to act as a buffer.
A buffer.
Yeah. They can take up the dopamine made from the L-DOPA dose and then release it slowly and steadily over hours. They smooth everything out.
But the disease doesn't stop.
It's relentless. And as more of those terminals are lost, that buffering capacity disappears. The patient becomes completely dependent on the moment-to-moment level of L-DOPA in their blood.
So instead of a smooth plateau of benefit, it becomes a roller coaster.
A total roller coaster. And this leads directly to those major long-term motor complications. The first one is usually the wearing off phenomenon.
And wearing off is when the effect of the dose just suddenly disappears.
Suddenly and dramatically, the therapeutic window just shrinks. A patient might be mobile and feeling on, and then an hour or two after their pill, they become rigid and frozen completely off.
Wow.
Their entire day is dictated by the timing of their pills. It's a huge management challenge.
And I imagine the temptation is to just increase the LDBTA dose or frequency to fight that wearing off.
Of course. But that leads you right into the second major complication, dyskinesias.
Right.
You're trying to maximize the on time, but when you hit that peak drug concentration, you overshoot and cause these excessive, abnormal, involuntary movements.
So they're trapped. They fluctuate between being off and frozen and being on but with disabling movements.
It becomes a pharmacological tightrope walk. It's incredibly difficult to manage.
So if Neil gets to that point and his doses are wearing off, how do we extend the benefit of each L-DOPA dose without pushing him into dyskinesia?
This is where our final major drug class comes in, the COMT inhibitors.
Okay, so we talked about carbidopa blocking the AEDC enzyme. What is COMT?
COMT, or catechol-methyltransferase, is basically the body's backup enzyme. If AADC is blocked in the periphery, the body's next favorite way to break down L-DOPA is with COMT.
So we block that too.
We're protecting L-DOPA from both of its major peripheral enemies. Drugs like entacapone are COMT inhibitors.
It's like a double shield.
It's a pharmacological double shield. When you take a COMT inhibitor with every dose of L-DOPA carbidopa, you extend L-DOPA's plasma half-life by maybe 30 to 50%.
Which means more L-DOPA gets to the brain for a longer period of time.
And that directly fights the wearing off. It makes that therapeutic window wider and smoother.
So that's the big takeaway for a student on the wards then. This treatment has to be radically personalized.
Absolutely. We started Neil at 68 on L-DOPA because the immediate risk of cognitive side effects and ICDs from a DA was just too high for him. That decision was all about his age and risk profile.
And his journey will be this constant balancing act, using tools like COMT inhibitors and maybe low-dose DAs to maximize his on-time.
While trying to keep the L-DOPA dose low enough to avoid severe dyskinesia and always monitoring for those neuropsychiatric side effects.
We're managing symptoms, and that's a powerful, important thing. But the whole conversation has been about replacement therapy.
It has. We're just giving the brain back what it's missing.
Which brings us to the final thought. The real frontier isn't just better symptomatic treatment.
No, the ultimate goal is a disease-modifying treatment. All the really intensive research now is focused on stopping the neurodegeneration itself.
How are they trying to do that?
They're trying to find ways to target the aggregated proteins like alpha-synuclein or inhibit certain kinase pathways like LRRK2. The goal isn't just to make the ride smoother for patients like Neil, it's to slow the train down or maybe even bring it to a complete stop.